Naveen. So here we are 35 today. So we are winning.
Yeah.
It's so hot that outside is almost impossible. My son is there. He's sitting up there in the garden, and there's a pool, and there he's sitting in there. Otherwise, there's no other way of surviving it.
Yeah, namaste everyone.
Namaste, namaste. Let me see. I have to shelter. I'll put some blinders up. I mean, how are you?
Namaste.
I'm doing fine. How are you?
Fine, thank you, thank you. It's a little bit hot here. It's very warm.
It's hot in Kathmandu also. I have a fan right next to me.
Okay, okay. Yeah, here it's a dry heat, so it's not it's not like humid, but it's very dry and it's extremely hot. But yeah, it's summer.
Yes,
Hello, Florian. Can you hear me?
Yes, I can. Yes, I can.
Robin.
Yes, hello. Namaste everyone.
So Sonia is also.
So how's everything, Florian? The weather seems good there.
Yeah. It's too warm actually, but otherwise it's okay. I mean, it's very dry. Hasn't been raining since I don't know 2 weeks or so. So nature is suffering, but otherwise it's fine.
Yeah.
We are lucky it's raining every day. I don't know. It's almost
It's
every day.
it's raining, yeah. It would be nice if it was raining here too, but it's not.
I don't know. Did it rain yesterday? I don't know.
I mean, you have
Whoa! Look at all these people.
Mustafa. Who's that? Hi.
Trying to talk.
Good
Hi there.
morning.
I'm trying to look at all these people on here.
Number of people today.
Who is Mustafa
Hello,
Haddad?
Dr. Dean. Hello.
Hi there. I'm Musfed. I'm one of the interventional radiologists at MCW. Dr. Klinger invited me to this meeting. I think we're hoping to go to Nepal October-ish to kind of talk about starting an IR program at your hospital.
Yeah, namaste, Dr. Mustafa. Thank you for joining.
So then there's Abhinas.
Yeah, Dr. Avinas is a MDGP resident, currently posted in vascular surgery here in Dhulikhel.
So why have they switched off the videos? Oh, what's that? Dean. It's ice cool, I suppose. Hello, Abhinas.
Welcome, Irina. Welcome, Avinas.
Hi, good morning. I'm Irina. I think somebody mentioned my name already. I'm at one of the hospitals in La Crosse, Wisconsin. I'm a vascular surgeon. I actually trained at Medical College of Wisconsin.
Yeah.
I don't know how many, about 11 years ago I did my fellowship, and that's how I met Dr. Klinger. So
Nice to meet you.
I've been around for some time now. Thank you for inviting me, and I'm also hoping to join the group in October. Really thrilled, working on the tickets and planning the trip.
Yes,
Oh, okay.
we all
So
are
Dean, I
excited to
mean,
welcome you all.
Dean, there's a big entourage which is going to Nepal then from your place, right? Dean. Isn't Dean listening?
I don't think he's listening.
So how many I mean if he doesn't answer then Irina, how many
there.
Oh man.
I was wondering why I couldn't hear anybody.
Yeah.
I figured out on my end.
Actually, it was nice, Dean.
Oh, it was nice not hearing me. Oh, thanks a lot.
Hi.
So I saw Irina talking. So has she introduced herself? Hi, Irina.
Yes.
Yeah, I said, Dean, so there's a big group coming from Wisconsin then this October.
I got email from another person last night. So maybe another one. And you met Mustafa?
Well, he introduced himself, but he didn't show himself in a video.
Well, it's kind of like me at most mornings.
Sorry about that. I mean, I have a baby crawling over me, so that's why I have the.
Yeah, so Irina's coming, as she probably said, and is bringing a resident with her. And Mustafa is an interventional radiologist, and he's working on when he is looking to come. And there might be, and Dr. Dan, he's coming, the heart surgeon, he's coming he'll be there beginning of November, maybe the end of October, while we'll still be there. And I have 2 residents coming, and maybe someone else, we'll see.
So who's working in Wisconsin then during the time? No one.
Well, you remember how my boss was angry with me?
Yeah, you told me.
Yeah, well, I've had that meeting, so we'll see.
And that's why, exactly. I get it.
I might be the one having to stay behind.
Oh, I see. Well, shift of knowledge. This is literally, right?
Well, we're expanding.
Yeah. Okay. Anyway.
Okay, we should get to work. Good morning.
Yes.
Good morning, everybody. Navin and
Good
Sonia
morning, Jordan.
and Swesha and Robin and he's fading in and out. So, all right. And then who's down on the one more person I don't know?
Avinash is a MDGP resident. Currently, he is posted in vascular surgery.
Great. Okay, let's start.
So once again, I'd like to welcome everyone in this meeting. So this is the 17th edition of our Global Vascular Meeting, which we are holding almost every month. And today, Dr. Satish and small team is busy in OR doing a case, so probably they will not join. And today we'll be presenting one case. Dr. Sanjay will be presenting one case. Dr. Florian will be presenting one case, and Sonia will be presenting preliminary finding. Sonia, along with Dr. Navin, will be discussing about preliminary finding of dialysis access research that is undergoing right now. So I would like to request Dr. Florian to present a case. So Florian, would you like to share your screen?
Yeah, wait. How does that work again? Let me see.
I've just seen Dr. Binay and Dr. Manis. So welcome. And Dr. Manis is a new medical officer in our team. So after Dr. Binay left, he has joined in our team, Dr. Manis. And also Dr.
So my screen is open. At least it says so here.
So can you share your screen?
You see it now?
Yeah. It's coming.
Okay. So everyone can see me, yeah? Yeah, for those who don't know me, especially those colleagues from the US, maybe Dean talked about me or talked about our collaboration. My name is Florian Thiermann. I'm a vascular surgeon from Germany, and I've been to Nepal 10 times, or I don't know, since 10 years at least, 10 or 11 times. And since several years, we are having this collaboration with Dean and his team, mostly residents who are joining him, and also others. There's usually another friend of ours from Netherlands who is joining us, who used to join us. So this is quite a good collaboration, and this is those monthly Zoom meetings are actually, I think, the result of the good collaboration. So when we're not in Nepal, we try to sort of stay in touch and discuss cases. So that is not only one time per year presents that we have, but it's an ongoing talking about cases and transferring knowledge, vascular knowledge, to Nepal. So in that case, or in that respect, I want to present one case which we did 7 weeks ago or 2 weeks ago, I don't know when. So it's about a complex reconstruction of insufficient AV access. And all I want to know is, I want to do is actually present this case and just give my thoughts, the thoughts we had when dealing with this case. And so I want to introduce this patient. It's a 75-year-old male in good health, by dysfunction of his AV axis. The dialysis unit, they told us, was an insufficient flow, had a recirculation problem. This guy had an AV shunt, a PTFE graft on his left upper arm, which was implanted 2016 in another unit. And so it was not done by us. It was status post shunt embolectomy, which we had done a year ago, and balloon angioplasty of, at that time, 2 stenosis. The right arm had been not touched yet. So we found, when we saw this patient, we found that there was a thrill palpable of the distal anastomosis. I'll show you the picture soon, or then next. Along the graft, there was a faint pulsation palpable. The auscultation gave a result in a high-pitched bruit over the anastomosis, and along the graft, there was only a faint bruit. And in ultrasound, we found that there was a stenosis at the distal, at the artery graft anastomosis, and in the middle part of the graft, or of the shunt, there were several more stenosis. The cephalic vein, interestingly, was located in its typical place, and the diameter was pretty good. It was 0.3 to 0.35 centimeters. So why it has not been used at that time, when the graft had been implanted, we have no idea. Maybe it was of smaller caliber at that time. We don't know. Anyway, what we did first, of course, is what we always do in ultrasound, after the clinical and ultrasound investigation. And so we tracked the shunt and did this painting on the arm to illustrate where the problem was. So what we see here is the distal anastomosis, is the graft artery anastomosis. There we see the alizing effect in the ultrasound, and also we see on the right photo this rigid stenosis, probably due to sclerotic plaques in that location. The second stenosis was there. You see that directly proximal of it, there's an aneurysm due to cannulation, supposedly. And then there's another stenosis up here, and then in the junction, or in the proximal anastomosis, as you can see here. So the question is, what should we do? And this question, actually, I want to ask you, and just tell me, what ideas do you have? I don't actually expect you to, I mean, give a solution within only a few minutes, because we also had to think about that case a little bit. So, but if there's anyone who has an idea what we should do next, or what the idea behind any kind of treatment is, then just say it right now. Any ideas?
Can you go back to the picture?
And can I ask a question to clarify? So your proximal venous anastomosis, is it your basilic vein? Is that what it anastomosed, or that number 4?
But number 4 is the axillary. It's way up.
Okay, that's not high. Okay.
Yeah, it's up high in the arm. Yeah. Gotcha. So you see on the very left picture, the big one, you see the arm without any markings on it, and then there's on the right. I can go back and just reduce. So this is, you see both the arm on the left side without any markings on it. On the right side, you see way up in the axillary region, there's the proximal anastomosis.
Yeah, that's pretty proximal. That's nice, because you're saving a lot of vein. If it's okay, I'll go first. Like, I would definitely explore the cephalic vein. So it's matured enough, or it's dilated enough over the years. But I'd also look at what basilic vein looks like too on ultrasound.
But for a second, this is the graft that we show, right?
This is the graft, right?
Okay.
Right, that's what you look in. This is the graft.
Okay, so you would go for the cephalic vein.
Correct, but it doesn't mean that you can still use the graft as your cephalic vein matures. That would be my thoughts. Still, so you avoid the catheter.
Okay. So, but in order to well, give the cephalic vein time to mature, what would you do with a, well, during that period? I mean, this person needs dialysis. You don't want to have a catheter. What would you do?
Correct. It is possible to still save this graft, continue to use this graft. So you would anastomose your cephalic till you break your artery. So you'll have two things. And once your cephalic matures, then you can tie off your graft.
Yeah, but the graft is not sufficient yet. What would you do with the
Oh,
graft?
I would plasty it. I would angioplasty. So I would angioplasty the areas of the stenosis.
You would angioplasty all the stenosis?
You may need to do a revision on the arterial one, but I would try to plasty first.
Any other comment?
Yeah, it looks to me like they're accessing this graft between site number 2 and site number 3. Is that correct?
Yeah, basically, yeah, mainly, yeah, you're right.
And the cephalic vein that you said was 3 to 3.5 millimeters, is that in the same arm or opposite arm?
Same arm, same arm.
Well, I think I would consider two things. One would just be do a whole new graft, start all over, and put a tunneled catheter in. But in Nepal, I wouldn't do that. And most likely, I wouldn't do that here either. What I would probably do is do 2 grafts, 2 sections. I would go from the artery up to number 2, you know, just beyond that stenosis, and then take another piece of graft and go from site 3 a little more proximal. And then you wouldn't even have to do a tunneled catheter. You keep accessing in the same place that you have been. And over time, you'll be able to access even between site 1 and 2.
Okay. So
That's
anyone
most
else?
likely what I would do.
Yeah, anyone else? Any idea? Robin?
So Florian, as discussed, like if it is possible to intervene any of the stenosis, then first of all, I'd like to go for intervention and angioplasty then, and secondly, as Dr. Dean mentioned, like we can, an option is to replace the graft, and for long-term uses, it will be better if we can use the cephalic vein. So if in any way, if we can do angioplasty for the stenosis followed by replacing the graft and also anastomosing the cephalic vein to brachial artery for so that after it matures, then we can use the cephalic vein.
So we see there are different approaches, but basically, I think we all sort of have the same idea. We want to avoid a tunnel catheter, and this is what we did, or what our ideas were, and they were pretty much as Irina proposed. Well, the summary findings was we have a main stenosis which is pretty rigid at the distal aspect. Then we have 2 stenosis along the graft, and we have a stenosis in the proximal anastomosis. Then we have this aneurysm in the middle part of the graft. And we have a good caliber of the cephalic vein. That's what we all find, what we all just mentioned. So the idea we had was the shunt can be probably salvaged for the moment, but we don't know for how long it will last, because one are fabrics, punctuation aneurysm, stage is past angioplasty already with those rigid stenosis. And the cephalic vein has a good caliber. So an autologous shunt is feasible. And we want to avoid tunnel catheter. So the plan was to solve the inflow problem first. And different from you, Irina, I don't see a chance for doing this interventionally because it's so rigid. And so we started right away from, well, the idea was to do a patch angioplasty there. Then solve the midway and outflow problem by doing intraoperative angioplasty. And if necessary, we would do another patch for the upper stenosis, and then create a new axis that can maturate while the old one is still in use. And only in case the shunt cannot be brought into function again, then we would have to use a tunnel catheter, but of course, at the same time, create the new cephalic shunt. So this is the intraoperative situs. That arm, the sketch you have seen already. So there you can see the slung graft, the brachial, the inflow brachial artery, or the cubital, and the outflow. This is the open part already. So we cross-clamped the inflow, outflow, and the graft, and you see how, I don't know if can you see my arrow here?
Yes.
You see that how it's moving? So here you see how this is all sclerotic, and there was actually no way, and that was actually what we had thought before. There was no way of would have been no way of just doing angioplasty here. So this was all cleared, and then we did the intraoperative angioplasty, and you see this is what it looks like. You see that aneurysm, and you see the 3 stenoses. So this one here in the middle, and the very proximal one where the proximal anastomosis was. So we did an angioplasty, and this is what it looked like afterwards. And I think we're all the same opinion. This is not a very good result, but we had a good backflow then, and we hope that it would be usable for several weeks. So we left it as it was because it's still better than it had been on the left photo. And then we completed the operation. This is the picture that you already know. There we sort of reconstructed the dorsal graft part into the anastomosis. Then we dissected the cephalic vein, swung it over, and then created this new situation, which looks like this is the vein coming from here as a patch into this hole that you just saw. This is the graft. Now everything is free from plaques or anything. This is the old artery and the old anastomosis. So now we have a wide inflow into the graft as well into the cephalic vein. And the idea was to still use that graft, even though it was not a very good result after angioplasty, and then let the new shunt develop. So this is the sketch. And post-operatively, the shunt was used. It was good. So no problem with that. The AV fissure had a very good thrill. The hand was warm, so no signs of ischemia syndrome, which could have happened as now, of course, the shunt, the blood divides into 2 vessels, like a graft and the cephalic vein. And we discharged this patient after 2 days. And the plan is, of course, to follow up this patient. He comes to the dialysis unit 3 times a week. So we are very it's very easy for us to follow him, and we'll discuss him also in the shunt conference. As soon as the AV shunt can be cannulated, it should be used. And this is what it looked like after the operation. So the take-home message, if there's a non-functioning access, I mean, we have talked about that, and it's just a repetition actually of what we should always do. We, of course, want to try to salvage the access if it's possible, put together all the information that we have, create a picture of what is the problem and how it can be solved. We need, of course, a bailout plan, which in that case would have been a tunnel catheter. In terms of technicalities, we have to restore the inflow and outflow, either by open surgery or by angioplasty. If possible, of course, we should combine both methods. And then, as we always say, think of the future. How long will the access last? In that case, for sure, it will not last for like half a year. So we have to try to think ahead, create the new one, which we did by using the cephalic vein. And yeah, we hope that it will mature and that we can then give up the graft and use the cephalic vein shunt. That's that.
Did you use the cephalic vein to patch that arterial anastomotic stenosis?
Yeah. No. Well, you're right. That's what I want to. It's not easy. See, it's this here. This is the vein here. Do you see my arrow?
Yeah. So so after, let's say the shunt clots, but the vein stays open. It's basically artery to a very short segment of graft to then onto the vein, correct?
Right, exactly. This here is the dorsal wall of the PTFE, and then it goes directly into the cephalic vein, which is here then, which goes over here, like here. And this is wide now after the thumb endarterectomy and after taking out all this sclerotic material. So this is wide. And I think we can see that on the picture here. This is pretty wide now. So this I don't fear any occlusion there anyway. I think the inflow is very good now. And as we patched it using this cephalic vein, there is there should not be a problem of like obliteration or stenosis again or so. So because now it's wide, you know.
So endarterectomy and patch.
Exactly, yeah. Okay, this is my case. Any comments from the Nepali colleagues?
Yeah, thank you, Dr. Florian. Very, very interesting case. And so my question is like, in terms of technical part, like the cephalic vein was about 3 millimeter, 3.5 millimeter, and the length of pass needed seems to be very long. So was there any technical issues?
What was very long?
The length of graph that needed to be passed using this cephalic vein seems pretty long. Like
Yeah, but you see, Robin, we dissected this vein well down into the region. It was long enough, actually. You know, it went down into the forearm, and so we could just swing it over. And of course, we tunneled the skin, swung it over, and then we could use it as a patch. I mean, you're right. Of course, it was not a matured vein, so the vein wall was pretty thin. That's right. So for that we needed loops and yeah, of course, meticular suturing and all that. But it was no problem actually.
So another thing is like, so from brachial artery, the blood will flow into two directions, one into the graph and another into the cephalic vein. So in
Yeah.
the follow-up in ultrasound, is there any like issues with the flow, like it's going to one direction more or something like that?
Well, you know, I expect actually the graph to become less sufficient within the next weeks or so. I mean, the thrill was good, so and as the cephalic vein was already 0.35 centimeters, I think the flow which now goes into the cephalic vein will be feasible. It will be enough to let it mature or maturate. I mean, what you mean is there's like a competitive flow into the PTFE. Yeah, that's possible. That's possible. That it's not enough to let the cephalic vein maturate. But yeah, I didn't see any other way actually of doing it. Just hoping that it will be sufficient, you know. But you're right. Could be a problem. Yeah. We will see. We'll see in 3 weeks or so.
Yeah, that's good. So, so if it is okay, can we move for another case discussion?
Of course, yeah.
And then give us follow-up on that in a month.
Yeah, yeah.
So we have about 9 minutes remaining. So after 9 minutes, we need to rejoin the same link. Okay. So now I would like to request Dr. Sanjay to present a case. I will be sharing my screen. So can you see the screen?
Okay, here we go. Yeah, I can see the screen. Okay. Hello, everyone. And most of the people in this meeting know about me. I'm Dr. Sanjay, medical officer in Vilkal Hospital. I joined Vilkal Hospital with Dr. Robin and Satish as a medical officer in this CTVS cardiothoracic and vascular surgery team. So and now I'm presenting a quite interesting case of a 59 years male with a known case of chronic kidney disease diagnosed 1 year back from Kathmandu. He's from Kathmandu, presented in a clinic with the complaint of decreased flow at the time of dialysis for a month, mild swelling of the left hand, and he had non-functioning right brachycephalic fistula created 1 year back, and he has a left brachycephalic area which is used for dialysis, and that left brachycephalic fistula was created 6 months back. He also has a history of central venous stenosis, for which he underwent angioplasty 3 months back in another hospital. He also gave the significant history of left side IV catheter insertion one time that was used for dialysis in the initial phase of CKD, and the duration of that catheter kept in the left internal jugular vein was for around 8 weeks. And he's also suffering from diabetes mellitus and hypertension since 2017. On the examination findings, he has mild edema in left hand with visible pulsation of the left brachiocephalic fistula. Thrill is absent over the fistula, but pulsation is present. Dilated collateral veins present in arm and anterior part of the shoulder and chest. A high pitch, predominantly systolic beat heard over this fistula. In ultrasonography, the anastomosis size was 4 millimeter. Stenosis of cephalic vein noted around 6 centimeter length, starting approximately 4 centimeter away from the anastomosis to the level of anterior axillary fold. It's quite long stenosis of cephalic vein, and the pulsatile flow noted with very minimal diastolic flow along the that stenotic cephalic vein. Normal caliber of vessel at pre and post in a stenotic side. Basilic vein size is 4.5 millimeter, but the segment of basilic vein is short, and the one finding that is noted in the ultrasound is the thick-walled brachial vein with a diameter 4 millimeter. And we plan for venography in cath lab. And venography, there is complete cephalic to axillary junction stenosis. We could not be able to negotiate the guide wire beyond this stenotic part, and then the you can see the stenotic part here, and then multiple collaterals present with the partial stenosis of brachial and some part of axillary vein, with normal contrast filling in the remaining central veins. And this picture is depicting the summary of the whole cases and the problem. There is outflow, obvious outflow problem with the combined effect of cephalic vein stenosis and axillary to cephalic junction complete stenosis. You can see the picture and find the conclusion of the whole cases. And now we plan for a resection of stenotic segment of cephalic vein with loop interposition PTFE graft placement between cephalic and basilic vein. And after the operation, the stenotic part of cephalic vein is resected and ligated. The PTFE graft is placed between normal portion of the remaining cephalic vein and the basilic vein. You can see in the picture 2. So in post-operative findings, good cells was present over the fistula, no hand soiling. Patient was discharged home, and we will be returned to the hospital after 1 week. So this is the our case, and then the now any queries? What could have been done differently, or we approach the case correctly, or there would be some changes or not?
Well, if I may start, there's one thing I don't quite understand. I mean, first of all, if the result is good, then you have done the right thing. Okay, so if this is if a now functioning shunt or an axis, then you did the right thing. What I don't quite understand is, maybe I misinterpreted the in geography. I thought actually that there was a central stenosis, like of the axillary vein or the subclavian vein, or was it? Or is it just that I didn't
So
see it right?
I think Florian's seeing it right. The axillary veins thrombose. And the textbook would tell you not to do what you did because of the central occlusion. But that being said, I studied 22 patients and found that you can do exactly like you did, because the collaterals are enough. What we found was that 70% of these people with occlusions, kind of like what you're showing, that you can actually create an access in that limb and it'll work. But like 30–40% will have arm swelling. And the patients just have to say, yeah, I'm okay with the arm swelling. So it can work. The textbook would tell you not to do that. A reason you may say it might work is because, well, the guy had a fistula in there before that was working without, well, he had some swelling in his hand, but anyway. So, right, Florian's right, but I think I know that it does work. Me, I probably would have looked at the other arm.
So, Dr. Jean, so as he already had made fistula in the other arm, so it doesn't seem to have any option in another arm. So in this case, initially, Satish and myself thought of connecting like basilic vein to brachial artery, but the length of usable basilic vein was pretty small. So we connected the cephalic to the basilic vein using interposition graft. And while interposing, we had ensured sufficient length of graft so that this can also be used in future, and you will not require basilic vein transposition because he has a good length of graft.
So, right. So another good thing you did was to make sure you had adequate